Hello everyone, I am Tanvi Shukla who is going to talk about Dentinogenesis Imperfecta. Introduction. It is an inherited disorder of autosomal dominant condition which affects both the deciduous and the primary teeth. Classification. There are three classifications: Shields classification, Wittkop's classification and revised classification. So Shields classification is type 1, which occurs in patients with osteogenesis imperfecta. Type 2, it is associated with osteogenesis imperfecta, not associated. Type 3, it is also called as Bradywine's type, which is a rare condition seen in racial isolates of Maryland, which exhibits multiple pulp chamber exposures. Revised classification: Dentinogenesis imperfecta type 1, which corresponds to type 2 of Shields classification, which is without osteogenesis imperfecta. Dentinogenesis type 2, which corresponds to type 3 of Shields classification. Dentinogenesis imperfecta type 1, also called as opalescent dentin or dentinogenesis imperfecta without osteogenesis imperfecta, Shields type 2 or capnodent teeth. Etiology: it is caused by a mutation in dentin sialophosphoprotein gene encoding dentin phosphoprotein and dentin sialoprotein. Clearly, it is distinct from osteogenesis imperfecta with opalescent teeth and affects only the teeth. No increased frequency of bone fracture is seen. Dentinogenesis imperfecta type 2, it is also called as Shields type 3 or Bradywine type of osteogenesis imperfecta. Etiology: some researchers say it is separate mutation from Dentinogenesis imperfecta type 1. Shield et al. In 1973 stated that there is an enlarged pulp chamber and pulp exposure occurs in deciduous teeth. Clinical features: it affects the males and females equally. Teeth are blue-gray or amber-brown and opalescent. Few days after eruption, teeth may achieve normal color, following which they become translucent. Finally, they become brown or grey with bluish reflection from enamel. Enamel may split readily from dentin when subjected to occlusal stress. Severe attrition of teeth is seen. Obliterated pulp chambers are also seen. Teeth are not sensitive even if most of the surface enamel is lost, as dentinal tubules are haphazardly arranged and most of them are devoid of odontoblastic process. Dentin is soft and easily penetrable but not caries prone because of structural change in dentin, which is little scope for microorganism entry due to obliterated dental tubules. Radiographic features: there is bulb-shaped or bell-shaped crowns of teeth with constricted cervical areas. The roots are thin and spiked. Obliteration of the coronal and radicular pulp chamber depending on the age. Cementum, alveolar bone and PDL appear normal. Type 2, large pulp chambers with thin shell of dentin and enamel, shell teeth. Next comes histopathology. Enamel is normal. Mantle dentin is narrow zone of dentin below the enamel, which is also normal. Remaining dentin is severely dysplastic. Reduced number of dentinal tubules are seen. Chemical and physical features is increased water content, increased mineral content, density and X-ray absorption and hardness are low, and microhardness are near to cementum. Treatment options aimed at preventing loss of enamel and dentin through attrition. Mild moderate cases, routine restorative techniques like amalgam and composites can be done. Bonding of veneers for aesthetic mask, opalescence of anterior teeth, bleaching to an extent lightens the color. Severe cases, there is significant enamel loss. Full coverage crowns for primary teeth, we can use stainless steel crowns in posteriors, and stainless steel will open face composite for anterior teeth, and permanent teeth porcelain fused to metal crowns.